My name's Jeff McPherson. I'm the market president for the East Tennessee market of Tennessee Orthopaedic Alliance. And I'm here today with a good friend and mentor of mine, Dr. Randy Robbins. And we're going to talk through the evolution of orthopedics over the years. And I'm glad you're here to talk about this with me. Especially since, we're friends, just as we do a lot of other things together. And I just thought it'd be interesting to share on this initial podcast your evolution as far as using technology when I took over your office as an office manager back in 2007. I mean, didn't I help you send a fax for the first time?
Absolutely.
And on email?
Technically, I still haven't sent a fax, but, prior to that time, we had paper charts, which had to be circulated around the office. There were no computers. Computers were just starting. We went from the StarTAC phone to the BlackBerry, so emails were just first starting to be sent. And when I joined TOC, as it was called back then, I sent my first email, my first fax. We started with PACS, which is our electronic X-ray, and it evolved from cumbersome paper charts that were this thick to laptops in each room.
And which office manager helped you get the digital PACS for the first time in your office that nobody else had at TOC at that time?
That was you.
Oh, that's right. It was me. Okay, just making sure. So as we've gone through several scenarios, just talking about this before we sat down together, there were a lot of things that you'd done preemptively to look at the history of TOC. Do you care just to give us a little bit of background on what that looked like?
No, not at all. History is important because we don't know where we are if we don't know where we came from. And so initially, back in the early 90s, the healthcare environment started to change, both politically as well as economically. Groups began to merge. There were a group of independent doctors in 1996 who formed something called Tennessee Orthopaedic Center. They merged with another group in Knoxville as well as a group in Oak Ridge, and that's what started TOC. National management companies started around that time. TOC became involved in OrthoLink. The OrthoLink's input was to start physician-owned physical therapy, physician-owned surgery centers, and MRI scans. In 2001, TOC made a very big effort to start total subspecialization within its practice. And what that means is most physicians, in the beginning would do multiple things, hand, foot and ankle, shoulder, subspecialization in sports, foot and ankle, spine really started. And that's where TOC started in 2001. And that's evolved to where we are today. And over the last 20 years, we have set up multiple surgery centers with physician input, multiple physical therapy centers, urgent care or after-hour clinics for patients to come into. And that all has been, again, physician and administrative driven. And to further that, TOA, which is a statewide organization, is a merger that we got involved with to allow our independence and to continue to have input with different surgery centers and different things like that.
So Knoxville, specifically East Tennessee, has grown dramatically over the past 25 years. Would you agree with that?
Absolutely.
So let's talk a little bit more about the specialized care. Why is that so important in the orthopedic mindset when we look at where we came from to where we are now?
I think the expectation and the results that patients want to achieve has certainly changed. I think the expectation to get back from an injury to being, if you will, normal has required as a physician to know the latest techniques. And it's impossible to know all the latest techniques or have all the skills in every subspecialty. And as the Knoxville market became a bigger market that like Nashville was or New York or LA, any other big market, we had to do that as well. And I think that's what really drove that.
So as we look at how it's also progressed, would you not agree that, as you mentioned with OrthoLink, the physical therapy, the MRI, CT scans, just some of those other things, that's an evolution that has almost been demanded of the patients just as healthcare has evolved?
Oh, I think so, because not only, as the world changes, it's, convenience factor, having offices in different locations. There's economic involvement. So you have to be on all the insurance plans. I think patients' time is valuable, and you need to get a good product. You can't be getting a generic, for instance, MRI scan read out generically when it's an orthopedic issue. Wow. And by subspecializing even that type of care, I think has really helped the patients.
So I know you know this, but I was a physical therapist assistant when I first started my career at then TOC. Yeah. And we were talking, and we've talked before about how the patient has progressed with the care, even from a physical therapy standpoint, where everything used to be a little bit more segmented.
I think so.
When I would do a home exercise program with a patient, I would expect that they would take the piece of paper I gave them, take it home, and not pick it back up. And that's why they came 3 times a week, so they could get their therapy and get it from us, because there was not a lot of patient education from that standpoint. It was more of us delivering care. It almost felt chiropractic, where the patient was dependent on us to do something for them. How has that changed just as we moved along?
Oh, I think you're exactly right. I think when I first started and I would walk into a room, the patient didn't ask any questions. The answer was, whatever you say, doctor. We'd move on. You would have really no involvement in therapy for 2 to 3 months, and then you'd start. And, as patients became more educated, as care became more educated, better, patients now have a huge input into their care. And we've all had to change. What you do today, or physical therapists do today, is in no way the way it was 30 years ago. And
go ahead. I'm sorry.
No, go ahead.
I think that that aspect of still having some patient care, though, has helped me as a leader to be able to communicate with physicians like yourselves as surgeons as support for your practice and what that looks like.
Oh, absolutely.
How has your work with the administration differed from what it was when you first started, even back when you first started in orthopedics 30 years ago, compared to what happened when you joined TOC and now even through TOA?
I think 30 years ago, the physician dealt with the hospital. There was no independent, there was no surgery centers. There was no other thing. Everything was dealt with the hospital, and physicians could not really change things. I mean, if the hospital wanted to do a certain way, that was it.
Do you think that was a payer issue, or is that more of that's just how they did things?
I think it was historic. I think if you look, for instance, how hip fractures were treated, you came in, you broke your hip, you spent 6 weeks in the hospital. Okay. Now, then it evolved till you spend a week in the hospital, and then the extended care facilities took over that. So I think that things changed. And then doctors wanted more input and wanted to change things. And I think clearly that drove a lot of the changes. And then what I think since 2007, what I've seen is that a cohesive interaction between, like you and I, the administration and the physician, just the communication has to be there. You don't know what I need, and I don't know what you need as an administrator. And if we can't figure that out, then it's bound to fail. And I think that's clearly been to everyone's advantage.
So you hit on a couple of points that some of my mentors, you being one of those, had pushed home to me just as I was working at TOC. And then as I've seen us progress into TOA, certain aspects of what makes TOA stands out. Listening to patient, listening them all the way through their conversations, being challenged when you're not getting the answers that you feel like you should be receiving from patients when you ask questions, and then the patient education aspect and listening with your eyes and ears. How have you been successful in your practice in carrying some of those things through with the changing technology, the changing times? Is it any different than it was then to now?
Communication is the key, and I, to this day, teach students that we see through, pre-medical students or med students or even PA students that come through. Communication is absolute. You have to listen to a patient. And even though technology changes things, And I've always said, like we discussed before, a patient will tell you what's wrong with them, even in every field. If you just listen, they don't know the pathophysiology, the anatomy. They don't know what's wrong with them. They just can tell you what's wrong with them. But if you listen and then apply your skill in physical exam with technologies that certainly have changed things a lot, that has never changed. And I think that doing a physical exam and listening to patients will never change and shouldn't change.
So AI won't take over that part. That your job's secure, right?
I think so. I think AI is important. We call them red herrings. There are things that are just weird and strange. And to tell a patient, I don't know, I need to figure it out, they appreciate that. I think AI will help with that. It'll streamline some things, but it won't take that away.
Okay. So I'm sure there's not many patients who are listening that ever had a chance to visit your office, as far your personal office where you did work and did some dictation and made some phone calls. But as I would walk into your office, even walking into your office now, there were pictures of family, there's pictures of friends. You've got, things from that are important to you, but specific to your office in Oak Ridge, when I would walk in, there'd be pictures of patients. Yeah. I remember one specifically standing on a high dive. And I remember some on the football teams that you took care of. Yeah. Tell me why is that important? Why did that drive you to do what you did? And why was it important for patients to give you pictures of what they did? I
think fundamentally, and AI can't change this either, but fundamentally the doctor-patient relationship should never change. I think patients need to be able to trust their physician, and patients want to. And I think when you are able to give the patient their, for instance, sports back, they get injured, they want to go to their pre-injury level, having the ability to do that, they're very thankful. And I think when they give you a picture of them back on the field or winning the state championship or whatever it is, show them that. And they walk in the office and say, oh, wow, he put that up. It meant a lot to him. And I think that's important in people's care.
So how did that transition into finding your passion for what you did in orthopedics? I mean, you're a retired sports surgeon, and I know you did other things just outside of sports, but how did that follow through into what made you to who you are as a physician?
I saw sports physicians when I did athletics when I was hurt. I played high school football, track, cross country, and then transitioned to triathlons. And at each level, you get hurt and you see a physician, and they get you back to where you were. And I remember when I hurt my shoulder in medical school, Terry Bradshaw's orthopedic surgeon, his son was in my class, and Terry Bradshaw would travel from Pittsburgh all the way to Shreveport, Louisiana, to get his care. And, that had a big impact on me that, that doctor-patient relationship is crucial. Once you set it up, patients will come back for life. And you're obligated to, continue to treat well, to continue to change your practice, to evolve with the times.
Speaking of that evolving, how did that evolving change in those relationships as you progressed in your practice from at TOC from 2007 to 2024?
I think when a patient likes you, they like their organization, they will stay with you. And it's our obligation as TOA to continue to stay current, active, use the latest technologies, and patients will continue to come see us. And how does that work in the administrative role? How do you all do the same thing?
I think there's a lot of that still holds true. Of course, we're not cutting people open and treating patients in the office, but there's the aspect of still trying to find a way to reach the patient and help them get what they need. As the patient is trying to find an appointment and find a time, they're more concerned about how quick can they get in to see you or see one of your peers. That's my role. Mm-hmm. I want to make sure that we're setting them up to see the right person so they don't feel like it's a wasted visit. I want them to be able to have the access they're wanting. So we've opened a lot of offices just to make sure that we're bringing the care closer to the patient. I think that's very important. The services so that it's a one-stop shop. You come in for your sports injury. but you have to go to Amazon and buy a brace, and it takes a day or two for it to get here. Well, you can just leave with a brace out of our facility. You need to have physical therapy. Well, how about a physical therapist that has a direct relationship with the doctor who's already treating you for the injury that you just saw them for? I think that's very key. MRI, just being able to say, hey, we've got an MRI that we can get you in within 2 to 3 days to confirm what's going on, or just to help give us a better picture of what's going on, all the way down to our new surgery center and what that looks like, from being able to schedule patients and control a lot of the things that we have there. I think my goal is to make sure the access is there for you all to get to the patients so that it's not impeding care in any way.
Do you think patients understand how hard the behind the scenes work from the administrative side goes, or is it appreciated, or have you seen that change?
It depends. I think some patients, unfortunately, have had to see behind the veil. They see the wizard moving all the gears and levers, and usually that has not been a good experience in those instances. But then I think there's also when they see how hard we're working to help them get what they need and the care they're needing, I think there's an appreciation that goes along with that. But my goal is hopefully patients never see the duck's feet under the water churning as fast as they can, that they just see something smooth and they see something that's easily delivered, and that is a way that they can get back to doing what they want to do.
I've always thought that probably the most important person in the whole office is the person either answering the phone or at the front desk, all the way to the back. What do you do as an administrator to keep that person and all the people within TOC happy so that the patients don't see that?
There's a lot of collaboration that goes involved. From the time that a patient calls and gets an appointment, the scheduler's goal is to answer that call in under 2 minutes. And right now they're successful at being able to do that. We have somebody who's sitting live in a chat. So they're just somebody waiting to chat with a patient who might not want to sit on the phone, or can be multitask oriented and be in a meeting at work while they're texting and chatting with us to try and get them an appointment. So I think there's a lot that goes on just to try and provide that access there. But then you're right. We've got a lot of people that patients never see. Verification of insurance teams, so that when the patient shows up, we're able to explain what their benefits are. Insurances, that could be a mess.
Sure.
And I think having staff that help explain that and help deliver what that expectation looks like, I think is very important as part of that visit. To the front desk, who give the patients the dreaded forms, a lot of which I know you don't want and you don't feel like you need, but some entity is requiring us to obtain that information. So trying to get that, and the front desk enduring some of those frustrations and sometimes even waits in the waiting room as far as what that looks like. All the way back to the medical assistants, the x-ray techs, the cast techs. It's that the collaboration of care. Everybody needs to understand what the goal is. The goal is to take care of the patient. It doesn't matter whether that's getting them in for an appointment, whether that's making sure they're welcomed at the front desk, whether that's helping them understand what their copay looks like and why, whether that's just helping them feel comfortable for an x-ray that they're going to be having, that it's just, mom sitting in the room and the injured athletes just going over with one of our staff member to feel more comfortable and just guide them through that process. Getting a cast on that, and all the pieces and the limitations that go on with that'll be attached to them for the next 4 to 6 weeks. So I think there's several things that our staff align on to try and collaborate to make sure that we're doing everything we need to support each other. We can't do one job without the next person doing the next piece.
Well, I know from the physician's point of view, an angry patient in the back sitting there waiting for us, because we do tend to run behind, is what we don't want, and we don't see that often. And so I think the collaboration is really working.
Well, so speaking about some challenges, I'm going to ask you 2 questions about a couple of challenges. Can you give me a challenge that still exists today that you dealt with since you've started practice through the time that you retired?
I think that from what, and we discussed this before, and I think the time it takes for something to heal, let's specifically talk about after a surgery, is a set period of time. And I think in today's order something from Amazon at 3:00 and it arrives at your house at 6, we can certainly speed up the healing of patients through minimally invasive techniques, through arthroscopic techniques, newer implants, all the different, we can talk about the different technologies, but it still takes, a certain amount of time, the biology of healing, for somebody to heal. And they may see on TV an athlete who has access in a professional setting to physical therapy 3 times a day, 18 people helping him. That's going to be very different from a high school athlete who lives 40 miles away from a bigger city and has very little access to any health care. And I think that's the biggest challenge we have is people want to get better yesterday. And sometimes that's a little bit hard to the expectations. We have to curve the expectations.
I was going to say that probably goes back to what you were talking about earlier, that patient communication.
I think so.
And setting that expectations and having the truth of this is how long you're going to be down for.
Absolutely. Because, the worst thing you can do is have a child go back to sports too soon because, quite frankly, the high school athlete is a very young teenager. They have the rest of their life we have to worry about the rest of their lives. They're worried about next week's football game.
Right. And
so I think tempering the expectations is still a challenge today.
Okay. What about the expectation of the challenge that has now changed through just the evolution of time? What's something that's gone away and is different that is no longer a barrier that it used to be?
I think the ability to have patients return to an excellent function is so much better now than it was in the past. I think we have so much more available in total joint replacements and scoliosis surgeries and sports medicine and fracture care, in trauma care. Those things have evolved today to the point where patient outcomes are so much better today. That's a double-edged sword because people have higher expectations, but patient outcomes today are 10 times better than they were when I first started.
And have some of the technologies, a few of which we've already mentioned, helped with that? I
think absolutely. I think, technologies, and we don't have to go into great detail, but things like biologics, chondroitin glycosamine, viscoelastic supplementations, PRP, stem cell, these things everyone hears about. The use of different metals and plastics and total joints with computer-generated, surgeries or computer-assisted surgeries, I should say, has really helped patient outcome. We still, and anesthesia techniques, give a little credit to that. They have allowed us to do things outpatient that, prior to, in 1994, if you had a knee replacement, you came in on Monday and you went home on Monday the following week. Now you go home the same day.
Right.
And I would have never thought that would be possible 30 years ago. Now it's everyday thing. And so I think the technology involvement, all of the product involvement has changed patient outcomes so much than it was before.
One of the things that just comes to mind specific to me, I remember when we replaced the first TOC MRI machine. Mm-hmm. That was one of my jobs as I'd stepped out of the physical therapy piece and helped the surgeons get their first real big MRI in the tube. And I remember a scan taking 30 minutes and the image quality working with that. And we had a 12-channel the MRI machine that was just, so fancy. And we were excited to have a 1.5 Tesla MRI. Not that means anything to anybody listening, but it was, a whole lot better than what we had. So we've gone through a couple reiterations and now we've just replaced the MRIs again and expanded services. So now we still have a 1.5, but the image quality for people that are laying in the tube, potentially claustrophobic and have motion, either with their breathing or anxiousness or just because they can't sit still, there's software to correct that.
Sure.
The scan time's only 15 minutes as opposed to 30 minutes.
Yeah.
We can scan 3 patients in an hour instead of just 1.5. So it significantly changed. Do you feel like there's advances like that have
absolutely
helped aid in your diagnosis?
I mean, I think the MRI has probably been the biggest thing. It's in sports medicine, shoulder surgery, things that I did back in the early 90s. It was a crapshoot. You really didn't know till you really got in there. Now you can preoperatively plan your surgery. You can tell the patient, okay, this is what we have with accuracy. Give them, for instance, meniscal tears. Back in the 90s, you could hardly tell if you had one or not. Now you can tell whether one's repairable, non-repairable. You can give them, okay, you may be on crutches, probably will be on crutches longer than this, that, or the other. And that helps with patient outcomes. I mean, they expect it and realize that it's not a surprise when they wake up. And I think that technology has, that and CT actually, with 3-dimensional CTs, specific, not to go into detail, but like in the shoulder, the socket or the glenoid placement of the total shoulder replacement has always been difficult. Now with CT planning, it's made it extraordinarily easier. And these things are all good for patients. I mean, the outcome is so much better.
So you're talking about the CT planning. Let's move into maybe a discussion about some of the pre-surgical planning. I know just as part of the other practice that you had, there was several components where you were able to use robotic assisted devices and move some of those things into the surgery center out of the hospital. How has that technology helped the care and treatment specifically in the surgical world to evolve?
Well, it's tremendous. I mean, the CT guided hip and knee replacements patients say, well, why do I have to get a CT scan? The ability to correct not only soft tissue, but bony abnormalities based on the CT scan, correlating with the robotic assisted surgery helps with outcomes tremendously. And people are able to get up and start walking right away as opposed to, having to do that all manually. And, I think the input that we do into the computer helps guide the end result. I think people think the computer does all the work. It doesn't. The surgeon still has to input what their end result needs to be based on everything. And then the computer helps make the cuts precise or helps balance. And so you need to work together with all of those 3 things together.
So do you feel like that the outcomes are longer for somebody who's going through a joint replacement now with a robotic assisted surgery? Or do you feel like the length of time's the same, but the functionality is better? Or is it a combination of both? It's
a combination of both. I think with, your physical therapy, with, we don't put them in the CPM machine. People say little machine that used to move their leg. Well, they're lying down in bed as opposed to being up walking around. And I think it's much better now, 100% better with the computer assisted outpatient therapy the next day surgeries. Patients are doing tremendously better.
We also mentioned briefly the surgery center, and I know that's a new exciting thing for us here at TOA.
It is.
And I know the other markets are looking forward to being able to have the same thing that we have here in our market in East Tennessee. But from an administrative standpoint, I like the ability to control what's ours. I like the ability to work with the anesthesiologist directly and be able to have those same expectations for our staff, provide the latest technology and all the things that make the surgery center nice, pretty, and new for the patient to feel. But what does it mean to a surgeon to own and operate a surgery center?
Well, I mean, when you work at a typical multi-specialty surgery center, the person helping you in surgery has to do other services, ENT, whatever. And having your own surgery center that's all orthopedic, everyone who works there just does orthopedic surgery. And that alone is, worth its weight in gold. That, and you work with the same people over and over again. They know your preferences. If something needs to be changed, you have the ability to fix it right away. There's not the pushback on, well, we have to go through a committee here, whatever. Having input, and input that can make positive changes is wonderful. And I think from every surgeon who works in a single specialty surgery center that they have input on, their outcomes are better because they're not having to fight through help, fight through time, fight through administrative issues. They don't have to. It's just a pleasant place to work and efficient.
So to that point, I've heard some conversation about, is it safe to be in a surgery center? You'd already stated that the evolution of orthopedics, for instance, for a total knee replacement, they were spending forever in the hospital. Now we're operating on people and sending them home within a few hours of their surgery. Talk a little bit more about how the surgery center can offer things that maybe the hospital can't, and why it's safe, and then at times when it's not appropriate for the surgery center.
I think we'll talk about that first. I think the surgery center is not for everyone. If someone is extremely sick, you have to evaluate their overall anesthetic risk, their overall health risk, and risk of doing the surgery in the first place. And I think if it is appropriate to do some surgeries in the hospital. The patient's not equipped to do it as an outpatient. They don't have the home, they don't live in an appropriate place, or they live alone. All those things. But that's not the majority of people. The majority of people have people that they can have somebody to help them at home. They're active enough to have an elective surgery. We have all of the things that a hospital has, all of the help, that it's not unsafe. And I think because of those things, I wouldn't do surgery in an outpatient setting if I thought it was dangerous. And I say if I wouldn't do surgery on myself or a family member, I'm certainly not going to be doing it at that institution. Sure. And I think most of the physicians feel that way. And patients have to also buy into that a little bit. Well, my first knee 10 years ago, I was in the hospital 4 days. What do you mean I'm going home? And that takes a little bit of, doctor-patient relationship, talking to the patient, and them seeing it to know that it would work. And I think that has changed in the last few years. Patients now understand that it is better and safer and faster to go to a surgery center.
So that collaboration that you're mentioning that we've talked about before, just with the office, how does that collaboration apply also to the surgery center when you're bringing in those services into that continuum of care?
Well, I think it's better because you're collaborating not only with management, anesthesia, but also the people you work with in surgery, and they can do not what we ask them to do, but what is the best way to do it, the best practice without, because, when you try to do things within a system, it's sometimes difficult to do. We've done it this way for 20 years. Why are we going to change? And that attitude is not prevalent at the surgery center because sometimes you have to change what you're doing. And if you think it's better and you do it and it's not better, you need to change it back. And I think we can do that in a quick manner, which is healthy and safe for patients.
I think that collaboration from a leadership standpoint is what's important to me and why it stands out that we needed one so desperately here. It just allows us like I said, that opportunity to continue to work together, to have that patient care-centered, focused mindset, and develop protocols, treatments, and plans that help just to align everything for what the patient is expecting their care to look like.
Oh, absolutely.
Without that, I think it would be very difficult.
Well, it would just be a different building with the same problems.
Right. So over your long, successful career, what's a story or what are some things that you're most proud of from your standpoint?
I think that one is the physician-patient relationships that I had. There's a family I think of today that I operated on 4 generations of their family. And, that's quite an accomplishment, I think, that they continue to come back and see you. And secondly, I think evolving the way I did things to change as technology changed. As you have to make an effort when you've been in practice 20 years to drastically change something you're doing. And you have to go about it the right way. You have to take steps to do it. And I did that. And I think physicians, for the most part, are doing that. And I think it'll change even more as we go forward, as AI will change medicine in some way, shape, or form. We have to look at the newest technologies and continue to do that. And I think doing that is what I'm most proud of, I think, over the course of the years.
You've been part of, whether it was in a hospital or residency fellowship, just other pieces of activities with other groups and in different institutions. What in your journey makes you most proud to be part of TOA through all these different pieces?
I think the way that the administration and the physicians are able to elicit positive changes is the biggest thing I've noticed at TOC and now TOA. I think if one becomes, if you will, more powerful than the other or more influential, we have to have the ear of the physician, and the physicians have to have the ear of administration. And I think we have to both work toward the same goal, which is continue to improve the way we give care.
We recently, of course, moved into the new surgery center, and we didn't quite get done on Friday. So we had Saturday and Sunday where staff were moving things in their cars and staying after and scrubbing things, and
including yourself,
including myself. You lead by example, right?
That's right.
So having all those things there, I think as part of that collaboration, one of the things I'm most proud of is the ability for our team just to throw down and get things done.
Yeah.
I can put a deadline in front of them. We can really work. There could be something that stresses the team really hard, but I know when it all comes together, that team approach is just really strong, and I'm really proud of that.
And you should be. And I think the physicians know that. I don't think patients know that, and they need to know that people are working behind the scenes to improve their care. It's not just a paycheck, or it's not just, paying your deductible, that we are trying to improve the way we do things.
How do you see TOA continuing to lead the innovation in patient access, just as we close out our time together here?
I think we continue to grow. We continue to change as the market demands. But at the same time, remember why we're doing it. We're doing it for patient care, for their improvement. And as long as we keep doing that, I think we'll do very well.
Okay. Well, thank you again for
you.
sitting down and chatting with us and all the different pieces. It's a good opportunity just to let everybody hear some different perspectives of some of our experiences over time.
It is.
So,
and thank you.
Thank you for listening.